wrong with the way that we fill things out. So it's really, really important to know how to do it properly. Okay. So we're going to go reasonably slowly. I want you to try and your best to fill out as much as possible. Take it in turns if you want. Do it together if you like. But try to do it. Try to do it. Don't just sit there and wait for me to go through the answers, because only by practicing it and doing it will you realise that there might be small things that you were a bit confused about. And it's better to get those all sorted now than to be fussing over them in a time-pressured environment in the middle of your answer, okay? So that's the point of this lecture, to kind of iron out all the confusion and like the little things, because I'm sure that a lot of you know how to do the basic stuff already. Okay, so we're going to work through cases just like you would have in your OSCE. So Mrs. XY was admitted with shortness of breath and chest pain to ward L4 in the LGI under Dr. Smith. These are all of her regular medicines. Can everybody see that? Yeah? I'd like you to write them all down on your drug charts, as if you're admitting them.
You don't have anything with the like stuff that's badly spread out. There was a massive pile of drug charts, so there should be at least enough 1, 2, 2.
Yeah, about 100.
Stop for me. Who doesn't have a drug chart? Oh my gosh. There's a whole area over there. Do you guys have one between two? How many people is there?
There's like 30 drug charts.
There's another one.
There are more than 6 people.
Can you pass them down? Okay, so if you don't have a drug chart, try writing it down anyway. If anyone has any questions, just put up your hand.
Can you write on the admission? We have to write the Can you write on the admission?
If they're drugs that they've been taking regularly before they've come into hospital, when you prescribe it, in the day box, you need to write on admission or OA. That helps us distinguish which drugs we've started in hospital and which drugs they've come in with. your first page should look like. So you've got your soprolol, dose is 5 milligrams, PO, which stands for oral, on admission. You have to have your name in there, your bleep in there, and in the OSCE, just write 1, 2, 3, 4. You don't want to waste time conjuring up some fancy number. Okay? And make sure you sign it, and don't forget to circle. A lot of people forget to circle a time. And just as a rule of thumb, always circle 8 for OD. Unless it's a statin, which we give at night, okay, or amitriptyline, some sort of sedative type medicine that is better given at night. But for everything else, don't waste your time fussing over, is it at lunchtime, is it in the morning, is this something that's given in the evening? Just circle 8 and move on. You don't have enough time to be fussing over things like that. And you're going to get a lot of them to prescribe, not just 2 or 3. So really, time is an issue. Okay? Fine. Does anybody have any problems with those? No? Okay, does your second page, this is your PRN side. That's where the oh no, sorry, this is the middle page of the drug chart, yeah? So here we've got allergy status, NKDA, known allergies. If the patient did have an allergy, you'd write penicillin, for example, in that box, and then you have to write what the allergy is. You can't leave this box empty. And that might come up in your OSCE, but they'll give you that information. So you have to write penicillin, rash.
If they haven't said an allergy, like you did in your scenario, are you fine to put NKDA?
What do you think? No. That's what this box here is for. This box here basically allows you to prescribe drugs without confirming the allergy status for a maximum of 24 hours. So if for whatever reason the patient doesn't know, you can't access the GP summary records at the time or there's no relative to ask, you can sign in here and with your name as well, and the date and the time, okay? And then this allows you to give anything and get away with it for 24 hours, okay? And the pharmacist on the ward normally comes around and checks all the drug charts and deals with these ones which are like this, okay? But otherwise, you must always fill out the allergy box like this. Any questions about the allergy box? Okay. You can put patient stickers on this bit. That's the easiest thing to do. They might give you patient stickers, but usually they don't. They just give you some patient details. So you just have to write first name, surname, hospital number, NHS number, which is the longer one, not the shorter one. The shorter one will be the hospital number. Sometimes it starts with a couple of letters. The NHS number will be a long number, which is purely digits.
Anchor, Dakshan's cleared out even the ward next door, so they only had 3 left.
Someone's over there.
So does anyone want there's just 3?
Yeah, something that way. There were like very few over there. Okay. And date of birth, make sure you write fully the date of birth. So write 1984, 1924, because patients, they could have been born in 1912 or 2012. So they're quite picky about that. And the same with bloods as well. When you actually fill out the blood forms and the blood bottles in particular, you need to make sure you fill out the date properly. Then you just fill out the date which they were admitted, your consultant's name, the ward, which is L4, and the hospital, which is LGI. Okay? Serotype, 1 per, which is written like that, and then twice a day. And it really doesn't matter which numbers you circle for twice a day. It can be 8 and 10, it can be 8 and 6, that's all right. Okay? Don't get fussed over that. It's not taken orally, it's an inhaler. And again, it's on admission, and the rest is the same. And this is the PRN side, okay? This is where the GTN spray goes. And that's pretty straightforward, isn't it? Okay, so we're going to move on. patient, I want you to complete the... Yes, but it's a spray, so you can just write it as you IH. You can write it as sublingual as well, but you get away with IH. Anything that's kind of sprayed into your mouth, you can get away with IH. Okay, slide 2. Same patient, I want you to fill out the chest X-ray request form. There should be plenty of those. And fill out as much detail as you can.
I just want to check who's got them.
Who doesn't have them?
I think there's another pile there.
That's because they haven't been handed out.
Sorry.
You hand it out that way. You guys hand it out that way.
You've got another 3 minutes to finish it, and then we're going to go. Fill it out as much as you possibly can.
So it would be that chair.
In reality, you're not going to get 3 minutes to fill out a form like this because you'll have a 10-minute station, probably there'll be a video, probably you'll have to look at a chest x-ray during a station. Probably you'll have to interpret some results. Probably you'll have to prescribe some antibiotics for pneumonia, calculate the curve 65 score, and probably we'll get this. So actually, if you haven't been able to fill it out within this space of time, you sort of need to learn how to, because you need to learn it and you need to figure out how to do it quickly. So, before I show you what it's actually supposed to be like, I want you to take a look at what you've got on your paper and especially make a note of what you haven't filled out, because that's probably what's going to stump you in the moment as well. Okay, I don't have a picture, but that's alright. You've all got a picture of the form in front of you. So, sticker, where the patient details are meant to go. Yeah? Otherwise you have to fill them out. Really, really important is you need to write the consultant's name on there. So in this case, you should have written Smith somewhere on that form. Otherwise they will fax it back to you. And it happens loads of times. Okay? Underneath, in the big white box where you're supposed to write the clinical information, you should have written 5 basal crackles, 98% on room air, other obs are stable, admitted with shortness of breath and chest pain, and you should have written also query something. So you need to be looking for something. So you could have written query MI, query heart failure, something like that. Okay? You should have written urgent. So in the, you've got 3 little boxes. You should have circled ASAP. Yeah? Because it says clearly in the information, urgent chest x-ray. You should have ticked chair. And you should have ticked LGI for location. And you should have written L4 next to ward. Next to the big box where there's a white bit where it says radiology, that's not for you to fill out. You should just leave that completely blank. That's for radiologists to put to protocol, put their stamp on it when it gets down to radiology. That's not for you. There's a box which says infection status. How many people filled that out? If you don't fill that bit out, your form will come back to you. Okay? So you should have written something like low risk or low infection status in that box. Okay?
Would you withhold that in the information?
Basically you have to presume that your patient has a low infection status unless they tell you in the information that they've come from a nursing home, they've been source isolated, MRSA swab was positive, they had loose stools and have been put in a side room. If they tell you that, then you write high infection status. Otherwise, you presume that they're a low infection risk. Okay. Underneath that, you should have written your name, your bleep number. You should have written the patient's name again. There's right at the bottom. Yeah. There's also a few boxes in between where it says, does the patient have diabetes? Well, no. So you should have circled no. And under allergies, you should have written NKDA. You should have done that. Even though it's a chest x-ray, you still should have filled that out. You don't need to worry about serum creatinine and all that stuff because it's just a chest x-ray. You only fill that out for CT and MRI and angiograms and things like that. And that's really. Is there any part of that form that you have any doubt about?
The inpatient type.
The inpatient type?
Yeah, so you've got chair, trolley, bed.
Yeah. You only tick one of those. So for this patient, you tick chair in the little box next to chair.
Okay. As well as in the transport required box.
The transport required box you leave completely out of it. That's only if the patient is an outpatient and they're needing transport to come and pick them up from their home. Okay, but because this patient is an inpatient, the porters are going to automatically come to them, so you just forget about the transport bit. Any other questions?
Did you say
you're always high risk if you come from a nursing?
They will have to give you some sort of information that is quite clear about the infection status. So they will say something like, from nursing home with loose stools, or from nursing home, recent MRSA swab positive, something like that.
Do you know that the consultant has specialty email address?
You don't need to worry about the speciality or the email address. The most important thing is the patient sticker goes on that bit and the consultant's name goes on that bit. Any other questions about this before we move on? So it's going to take you less than a minute to fill this out in the OSCE, yeah? Right. Next one. Okay, we're still with Mr. X. We're still with our same guy. During his admission, his hemoglobin drops to 8. You do a thorough examination and you discover that he's had some leaner as well. So you organised an OGD which discovered he had gastric and duodenal ulcers. And this was because he'd been started on aspirin recently, only a week ago, with no PPI cover. There wasn't any active bleeding on the OGD report. If there was active bleeding, what would it mention on the OGD report? If there was like actual bleeding happening when they scoped. Or visual? No.
What intervention they've done to stop it?
Exactly. And normally, he said what intervention they've done at the time. Sometimes they don't actually clearly say active bleed, but they will say something like injected with adrenaline. And then you know, okay, there was obviously something actively bleeding that they had to stop them in there. Okay? So there was no active bleeding in this chap. But they said that he was likely to have bled from his duodenal ulcer. Oh, by the way, he also had esophageal candidiasis, just as a side note. So what treatment does he need? Just shout out, what treatment would you have to give to him? Yeah, so he's going to need a high-dose PPI, like what? Yeah, omeprazole 40 milligrams or lansoprazole 60, high dose. Yeah, you can give 60 milligrams, so you can do 30 milligrams BD.
Guys, what's the cut-off when you have to prescribe blood?
Okay, get asked this loads. Basically, hemoglobin of less than 8, or very symptomatic, or actively bleeding from somewhere. And you asked a question. Oral. If this patient had bleeding ulcers, according to the guidelines, you'd have to prescribe an IV infusion, which would be 80 milligrams of lansoprazole. This is like just your general treatment for a bleeding peptic ulcer, yeah? So you put them on an IV infusion of a PPI of some kind, yeah? But because this wasn't actively bleeding, oral is fine, you need to give them a high dose of a PPI for 4 weeks and then keep them on a maintenance dose after that for a bit longer. What about the esophageal candidiasis? What do you want to give for that? What did you say? Fluconazole. Yep, so some oral fluconazole for about 10 days. Okay, now I want you to prescribe it. So can you please prescribe me 30 milligrams of lansoprazole BD and prescribe some fluconazole 50 milligrams once a day for 10 days. If you don't have a drug chart, write it down anyway. You know what all the boxes are, don't you?
Yeah.
did that. You should have done that. Because he's got ulcers secondary to his aspirin, right? So that aspirin needs to go. And this, and I'm sure for those of you who've come to the previous sessions, you'll know that there have been previous OSCE stations where you've got upper GI bleed. Please prescribe a series of medications, and you have to cross off some of them. So when someone says prescribe something, at the same time, they're telling you what you need to cross off, so don't forget that bit. If you leave this guy on aspirin, that ulcer is not going to get any better. Okay, so when you cross something off, that will do, whatever, but make sure you sign it, make sure you date it, and make sure you write something about the reason why you stopped it. Why do we do this? Does anyone know?
If somebody comes in tomorrow and says, why aren't they an aspirin? They've got a reason.
Exactly. Because if somebody different comes on the ward round the following day and they've seen that the aspirin's crossed off, they're going to clearly know why that's been done. They won't have to flick through all the notes to figure out why. Especially when this is 2 weeks down the line and the patient's still here and has had a whole load of other problems. Okay, so it's really important that we keep a trail of what we're doing with medicines. And it's very useful when it comes to writing the E down as well. Okay, and page 2 should look like this. So there is your lansoprazole, BD, 30 milligrams, and I've written new. So it's clear that that is something we have started during his admission. Notice how I've written the date as opposed to on admission. So who did that? And who wrote new? Whoever did that, I'd be very, very, very impressed. That's like what you get your honours points for. And then fluconazole, 50 milligrams. You could have circled any of this. It's absolutely fine. Who wrote for 10 days and the indication? Any type of antibiotic now, you have to write in this box how long it's for and the indication, otherwise you will lose the mark.
You cancel it after 10 days.
You still have to write the box. You can't get any clearer than that. Okay. Let's keep going. We've got a new patient now. Mrs. White has just had a laparotomy for excision of a rectal peritoneal mass. She was transferred to HDU after her operation. She had an epidural in, and now it's come out, and she's been transferred to the ward. Somebody forgot to prescribe pain relief for her. She was entirely dependent on this epidural, and now it's up to you. So, prescribe her some pain relief. I'll give you a tip with this one, okay? Don't just prescribe paracetamol. Prescribe all the pain relief that she's going to want, otherwise they're going to pull you back every time she needs something a bit more. And prescribe everything that she's going to need to combat the side effects as well. on the PRN side? Who put all the pain relief on the PRN side? Okay. Who? What was that? Not all of it. What did you put on the PRN side and what didn't you? Right, so you put breakthrough pain on the PRN side. What did you actually prescribe though? What drug? Oromor, okay? And then you put everything else on the other side. Is that right? Is that what you've done? I don't know who I'm looking at, so you know, don't get embarrassed. Yes, okay, fine. It seems that you're the only person who's used the PRN side at all. Who else? So has everyone else written it up as regular? Okay.
Use the PRN side for antiemetic and naloxone.
Okay. And everyone who put it on the regular side, why did you do that? Why did you put it on the regular side? So you wanted the baseline. Right, this is the thing, okay? The thing about an epidural is that it can go, you can increase the rate and you can reduce the rate. This lady has come off it completely and she hasn't been taking any regular medicines alongside it because that's what you've been asked to do, to prescribe her regular medicine. So we don't know what her baseline threshold is at all. There are lots of correct ways to do this, but I'm going to tell you a really, really correct way to do this.
Would you have been told whether she can take things orally yet?
Yeah, she can take things orally.
Okay, would they normally say that in a scenario?
You just have to presume that she can. She's a few days post-op. There's no reason why she can't. Yeah. Unless they give you a reason why she can't. Say she now has swallowing difficulties or an NG tubing or something like that. There's no reason why she can't take everything she thinks. Okay? So, whose structure looks beautiful and tidy and wonderful, glamorous like this?
Would you put her on the
Okay, right, just to avoid confusion, we are talking about a different patient now, okay? So you wouldn't have given diclofenac to the peptic ulcer guy, okay? But basically, you need to show that you would go up the analgesic ladder. All of this is theoretical. You want to show the examiner that you know your stuff. Okay, so you start with paracetamol, 1 gram. Remember that there is a principle to filling out this PRN section, just like there's a different principle to filling out the regular section. You have to write a frequency. That frequency preferably has to be in hours, so not TDS or BD. Ideally, it should be in hours. There should always be a maximum dose. Always, always, always. There are some really irritating drugs like salbutamol and GTN where it's just PRN. There is no maximum dose as such. Okay? Can't do anything about that. Doesn't fit. Whatever. But the principle is that there should be something in here and there should be a reason for the medicine that you're giving as well. And normally you just write pain. Okay? And don't forget the date, don't forget the route, sign, name, and bleep number.
Surely we wouldn't have time to write all that.
Yeah. Yeah. There's no difference between writing it on here and writing it in the regular side.
But how much is that down to the nurse's discretion though? So like, oh, I've gone to see the patient, I've given them some paracetamol, shall I just move down? Is that what you say to the nurse?
It is entirely at the nurse's discretion, not just a little bit. It is up to the nurses to monitor this, okay? You don't know what the patient's baseline pain threshold is. You don't know how much of this she's going to need. Paracetamol might be enough. I mean, she's come off her epidural completely, okay? She might need a bit of tramadol. She might need a bit of codeine. There might be something that she prefers. She might prefer codeine to diclofenac, for example. Okay? But if you prescribe all of this, you're covering all your bases and you won't get asked to come back just to prescribe something different, which is very annoying. Okay? So we're going down the analgesic ladder. Calm down. going down the analgesic ladder, you've got your paracetamol. What comes next? Some sort of NSAID, yes? So we've got your then you go on to your opiates, your codeine and your tramadol. And then you get, your strong opiates, your Oramor, yeah? And then you want to put all the bits and bobs which counteract the side effects. So you should have an antiemetic, you should have some sort of laxative, Senna, 2 tablets at night, or Laxido, 1 sachet, twice a day, lactulose, 15 mils, BD, something like that. So you need to pick one of each and just input that and hang on to it, okay? Because that's what you don't want to be like trying to recall all this stuff. You will get a BNF whenever you're asked to prescribe something. There will be one there. But do you know how long it takes to look stuff up, the BNF? You probably won't have time to do all that. So go into your OSCE armed with some basic dosages and basic information, okay? An easy way to remember with, the timings and stuff, everything except for diclofenac and NSAIDs are QDS. So ibuprofen, diclofenac, always TDS. Everything else is QDS. That's just one easy way to remember. If anybody wrote paracetamol on the regular side, that's not wrong. For a really good student, they would have looked at the age of this patient. And if the patient was old, they would have given a lower dose of this Oramor. They would have given it as 2.5 milligrams and a maximum dose of probably 10. But if you've got someone quite young and fit, 2.5 is a very, very small amount. Okay? Are we happy with that, or does anybody have any questions?
So, do you think you would need to prescribe naloxone?
Yeah, you could do, and I don't think they'll ask you to do that though. It's a bit complicated.
Is it okay to have 3 different types of opioids?
Is it okay to have 3 different types of opioids? In what sense? Yes. Basically, you're trying to suss out what this patient is going to want, okay? So some people prefer tramadol and some people prefer codeine. Normally, you give codeine and then if that's not enough, you top up with oral. So yeah, that's absolutely fine. It's because it's on the PRN side and not on the regular side, you get away with it. If you prescribe 3 different types of opiates on the regular side,
Can you say that again? I didn't hear you. It sounded important.
Alright, somebody asked me if it's okay to prescribe 3 types of opiates, tramadol, codeine and Oramor. If you write on the PRN side, you can get away with it. If you did that on the regular side, you would not be able to, that would be like a fail.
What if the nurse decides to give the patient tramadol, codeine and Oramor?
Well, that's up to the nurses. That's up to the nurses.
If the nurse gives 3 opioids and sends the patient into a true depression, that's your fault, not the nurse's.
Yeah. No, it's not actually. You can prescribe this, but you don't have to give it. What you've done by prescribing it on the PRN side is you've given your patient and the nurses some options. Okay? It's not, if you prescribed it on the regular side, that's different. It would be your fault. But on this side, it's the nurses.
There's nothing on there to say don't give those 2 together.
Firstly, you can give codeine and Oramor, and you can give tramadol and Oramor together. That's okay, right? The problem that I have is if someone gave tramadol, codeine together, or tramadol, codeine, and Oramor. But it's very unlikely that that's going to happen. And if you really don't want it to happen, you could just cross off the tramadol. Yeah. If you really wanted to. The reason why I put down all 3 is because from my personal experience, I know that patients prefer one thing or the other thing. I've seen loads of people who get really dizzy on tramadol but are perfectly fine with codeine. And if it's 3 o'clock in the morning, you're not going to go wake people up just to find out which one they prefer.
Couldn't you just write somewhere, anywhere on that? Just say either tramadol or codeine.
Yeah, you could write either or something like that. There's no actual space to write that though. Yeah. Any other questions? But you know what? That's really good thinking. Really good thinking. And like, you know, we're talking about the theoretical and then what happens in reality. Theoretically, I guess you're right. But in reality, it doesn't quite work out that nicely. Alright, let's keep going. I'm not going to go over the analgesic ladder, you know that. Mr. Z normally is on warfarin 5 milligrams OD for AF. He's just come in, prescribe it. You get 1 minute to do this. And we're going to move on. It's like the easiest thing to do. Okay, take a look at your piece of paper, look at what you've written, what's confused you, make a note of it, because that's probably what's going to confuse you in the exam. If you haven't filled out anything, I hope you're paying attention. This is what it should look like. Yeah? You can, again, put a patient sticker up here. You still need to fill out the consultant, ward, hospital. The anticoagulant is warfarin. Is always warfarin. You don't put aspirin on here. You don't really put clopidogrel on here. It's usually always warfarin, okay? The target INR for AF, you should know off the top of your head, is always 2 to 3. For metallic valves, it's 2.5 to 4, well, 2.5 to 4, but I usually think 2 to 3 for AF, 3 to 4 for metallic valves, keep it simple. PEs, DVTs, 2 to 3 as well, okay? This is the dose that the patient was on before they came in, and that's the dose that we're going to prescribe to them, okay? We don't know what their INR is because we haven't checked it, we haven't been given that information, so you can just put dash there. Make sure you date it, make sure that you signed it, you've written your name, and you write your bleep number, even though the chart doesn't ask for it. Heparin goes on a different chart. You don't need to know about heparin. It's a lot more complicated. You won't get asked about it. So don't worry about it. Okay, so the next day, his INR is 3.6. This is because one of your FY1 friends prescribed him some antibiotics as well, and his INR went crazy. So, how would you dose his warfarin now? You don't miss it. Dosing, okay? If the INR's up, the warfarin needs to go down. 4.5, because 3.6 isn't massively out of this therapeutic range. 4 milligrams is also acceptable. Less than 4 is a bit optimistic. Omitting it entirely is a little bit unacceptable, purely because if that patient's INR went below, it's very difficult to bring it back to therapeutic level. And they can have a stroke or something, or a clot within that time. So this is really a question about warfarin dosing, okay?
So would you then check the INR?
You would check the INR the next day.
Where did you get
Experience, like I said, 0.5, 4, it's up to you. You can't know because people react to warfarin differently. But milligrams isn't wrong, 4.5 isn't wrong either. There's no way to Right, moving on now. The next day is INR is 5.6. So how would you dose of warfarin now? You're going to have to do this very, very confidently next year. You have to prescribe maybe 3 or 4 warfarin a day.
Sorry, you're not using that.
No, just ignore that. I'll explain in a moment. Ignore the chart on the back page. Thank you for what you've written. Before I show you the answer, there was a lot of grumbling. I think I've really upset a few people by what I just said. What is the problem?
back?
The back page. Ignore it. Why is that a problem?
Because
We don't know.
we're not
So explain
experienced.
to us what we should do. Because we
Right,
don't know.
fine. I will explain it to you. This patient has come in on warfarin. They've been on warfarin for a while. They're not new to warfarin. The back page is only for people that are starting on warfarin. So if they've already been on warfarin, it's up to you to do the adjusting. Ignore the back page. Okay? The back page is not for this patient.
So like, but if someone, but on the back it's like day 4 and beyond, so it's just like.
They're not on day 4. They're on like day 11.
This is and beyond.
Like, so that's why we're confused.
Right, that's still for the very beginning though. When they mean and beyond, they mean like day 5, day 6, day 7, day 8. They don't mean like a year from now, for example. Ignore the back page.
So just adjust it according to.
Adjusting it using your own clinical judgment. Okay? Your own clinical judgment. Okay, so what did people write? Whoever wrote omit did well. What did you wrote 2.5. You could kind of get away with 2.5. That's pretty low.
Yeah. I just thought that so the INR is double what we want it to be, so give them half a day.
Okay, right. So yes, the INR is very high. Yeah. I see what you're trying to think mathematically, aren't you?
How high do you want it to be before you omit it?
I would say anything above 5 you omit, because remember, if we think back to patients who are bleeding and on warfarin, if they have an INR of less than 8 but not bleeding, what do? You give them oral Vic K. If they are more than 8 and bleeding, what do? You give them some IV something or other. If they're more than 5 but not less than 8, more than 5, you give them Vic K, right? This patient, but they have to be symptomatic as well. So less than 8 and bleeding, you give them Vic K. So this patient's more than 5 and asymptomatic. So just omit it. Does that make sense? Remember your 5s and 8s when it comes to the warfarin and bleeding risk. Yeah? Those are your important numbers. Did I confuse people? No? Okay.
Should you write a line?
You don't write a line, you write omit. Where it says dose, where the dose normally goes, you write omit. And you write the INR in the box, and you write the date and everything. Okay, so this is where we use the back page, right? Mr. A, he's 80, recently been diagnosed with AF. The consultant asks you to start him on warfarin, so that's when you use the back page. I'd like you to use the back page and prescribe it. Okay, so the back page is what we call Benedetti's protocols. You will have come across it because it's one of the things you need to get signed off on your little blue book, yeah? So, on the back there are two charts. One of them has a much lower dose for starting, and the other one is double it. There's some criteria that is written down on that chart. Things like age, other comorbidities, and if your patient fulfills any one of those, then you start with a lower dose. So does our patient fulfill that criteria? Yes, because he's 80, right? Okay. So you start with the lower dose. So what are you going to, and this is where we talk about loading warfarin. So what are you going to load him with? 5 milligrams. And then what are you going to do? Check his INR. So the next day his INR is 2.3. What are you going to give him? 4.5. The next day his INR is 3. What are you going to give him? See, it's so simple. That's it. That's mystery solved. And that is what the back page is for. Okay?
So, can I ask for the first person?
Yeah.
If they're on warfarin,
Yeah.
would you need to be testing their INR every day if they're in hospital?
If they're on warfarin and their INR has been stable, you can usually check it every 2 or 3 days.
So then, do you still need to write it up every day on this chart?
You still need to prescribe warfarin every day to that patient. So you'll always have to fill out the warfarin chart. You can put a dash where the INR is.
Okay, so every day when you're on your ward round, you have to like write it out.
You have to prescribe another warfarin.
But can you prescribe 3 days in a row, you know, reaching the INR?
Yeah, sure. But only if their INR has been stable. Now, if you've got a patient like our first patient, who's come in with this 5 milligrams that they're taking every day, you don't know that their INR has been stable for the past couple of weeks. That's why you check the INR. And you discovered that actually his INR was really high. And then you keep on checking it until it's stable. If your patient's been in hospital for a few days and their INR is very stable, you don't need to check it every day. 2 or 3 days is fine.
When you start on Norfolk, how many days do you need, providing it's within the limits that you want, how many days do you need to keep checking?
Well, provided I would check it every day for the first few days. Yeah, if it's suddenly gone from like 1.1 to 2.3 to 3, I would actually check it the next day just to make sure that it doesn't go to 4 or something. So that's quite a big jump. But some people go up very, very slowly. That's more likely. It really depends on the pattern. It's just common sense, that's all. Yes?
If you have a patient who's on warfarin for something like metallic heart valve and
Yes.
you've got to reverse it,
Yes.
would you give them like low molecular weight cover or something?
You would always give them low molecular weight cover. So if you're going to stop the warfarin, say they're going to go for an OGD or they're going to get a PICC line put in, something like that, where their INR needs to be sub-therapeutic, you start them on a heparin infusion to cover them.
So if you reverse them, you do that?
Yeah. Okay? That's normally only for like metallic heart valves. Okay, slide 10, we're nearly at the end, okay? So hang on, because this is all the stuff that could come up in your OSCE. Mrs. B's bloods have come back. She's in AKI, obviously. She needs fluids, so prescribe them for AKI. give? Just guess. That's how confident you are with what you prescribed. Okay, normally, if you're in AKI, you give 1 litre in 1 hour. And I know you're going to ask me, of what? It really doesn't matter. Sodium chloride, 0.9%, is what we've got on the wards everywhere. It cures AKI. If you've got a tiny lady or someone with heart failure, then you have to use your clinical judgment. It might not be an hour, it might be 4 hours, it might not be a litre, it might be 500 mils. But in your OSCE, you're going to get some simple scenario like this, just to check that you know the basics. 1 hour, 1 litre of anything. Okay? So, this is what it should look like. So you've got date, sodium chloride, 0.9%, 1 litre, 1 hour. You cross that off because obviously they're an AKI. You're not even going to think about giving them any potassium at this point. Sign it, write your name, and you should have all of this filled out as well. Okay? That's pretty straightforward, isn't it? So Mrs. K's bloods have come back, and she's now hyperkalemic. So I want you to go back to your drug chart and prescribe everything, and your fluid chart as well, for hyperkalemia. And do it quickly. It should be like eyes closed, in your sleep kind of stuff. Maintenance fluids for 24 hours. What options have people gone for? Dexalan. Okay. Any other options? You can also give sodium chloride, 0.9%, 5% dextrose, 5% dextrose as well. Okay? And it should look something like this. And don't forget, 20 millimoles, 20 millimoles, 20 millimoles.
Why are we giving her potassium if we're treating for hyperkalemia?
We're not treating, but this is just for purely just maintenance in general. Forget this patient. You've been asked to prescribe some maintenance fluid for a patient. You need to. This is the theoretical.
In this scenario.
In this scenario, you would no. In this scenario, you wouldn't give Yeah. If my patient was hyperkalemic and AKI type, I would give this, but not. Right, now we're moving on to the BTE forms. They're like blue and white forms. Okay, Mrs. S admitted to bilateral mastectomy, 75-year-old lady, normally fit and well and mobile at home. Her past medical history of heart failure, AF. She's never had surgery or clots before. Fill out the BTE form and then prescribe some thromboprophylaxis.
You'll be able to say Saturday. It's a very obvious shape.
She's not on warfarin. She's on acid. Although, if she was on warfarin, you wouldn't give her anything. But another reason, the other thing is, if she was on warfarin and coming for a surgery, her warfarin would have been stopped for about 3 to 5 days beforehand, so her INR would be subtherapeutic. So it would be okay to give her prophylaxis for a period of time, even treatment pins later down the line, just to get her warfarin INR back up to the therapeutic range. Alright then, let's keep going. So your BTE form should look like this. So you've taken a surgical patient, you've written all the, again, patient sticker can go here. She's older than 60, she's got other comorbidities, she has, or she will be significantly reduced for 3 days or more. Surgery with significant reduction in mobility is the same thing. Basically, this section here is really for old elderly patients or someone who's fallen over and has been less mobile before they were admitted. But you can take that too. No one's going to penalise you for that. Okay, hang on a second, one at a time.
We're starting a bilateral mastectomy, so she's not working
yeah, they're cutting it out. But yeah, you could have taken it out as well. Yeah, should have taken the cancel. Right, next question. Is there another question?
Is a surgery going to last more than 90 minutes?
Bilateral.
Yes, because it's bilateral. There was another hand up somewhere. Okay, the important thing about this form is that you pick stuff. This is all very interesting. This bit is more important, okay? Because if they're going for a lumbar puncture, they should not have thromboprophylaxis, especially not TINs, maybe something else. Yeah, so this section here is the one that you need to really look out for. If they're going to trip you up in your OSCE, they'll give you something that goes in these boxes, okay? Then just sign, date, and you have to sign here as well to say that you've actually done something about it. If you're not going to, if you've decided, okay, this patient is not going to go convict him, you need to sign this bit. Oh wait, sorry, this bit here. No intervention required. Then, on your drug chart, you should have something like this. Okay? Tick that you've done the risk assessment, the VTE form, sign it, date it, tinzaparin, 3,500 units, because she's an elderly lady, because her EGFR is probably rubbish, yeah? On admission, subcut, and you circle the time. A lot of people forget to circle the time. If you don't circle it, they won't give it. And because she's a surgical patient, you should have given her some stockings as well. The only patients you don't give stockings to are vascular patients who might have ulcers and peripheral vascular disease or something like that. But any surgical patient should have both of these. If they're medical, sometimes they just have that. Any questions?
How much would you give them if they were just like a normal patient?
How much would I give them if
they weren't old?
If they weren't old, it'd be 4,500 units. Any other questions? Yes, enoxaparin is the preferred thromboprophylaxis for any patient who is elderly. It's normally 40 milligrams, but because she's a surgical patient, it's still TINs. If their EGFR is less than 30 or they're renal failure patients, then you give them 20 milligrams of enoxaparin. If they've got some sort of ACS, fondaparinux is what's given instead. But that's really complicated. You don't need to know about fondaparinux. Okay? That is pretty much every form that you're going to get in your OSCE. You probably won't get insulin charts. You probably won't get vancomycin charts. It's very, very, very unlikely. Yes, you can. Yes. Well done, everyone. Okay, before you all go, I know this is a massive ask. Please fill out a feedback form.